Hi guys, my name's Aisha and I'm a dual qualified foundation doctor and also the OMFS Survival Guide programme lead. This talk is the first one in the bloods interpretation and we're going to go over the FBC and CRP. So the aims and objectives of this talk are to give you an overview of indications for ordering an FBC and a CRP blood test. We want you to be able to understand the pathophysiology behind certain trends in those blood tests and to also understand which cases might need further investigation or management by either our MaxFax team or another medical team. So in the usual OMFS Survival Guide fare, we're going to be going through some cases. So I want you to imagine that you are on call and you have a 45-year-old female called Sumi who's been referred by A&E. She's referred with a right-sided upper cheek swelling and she was brought in by one of her friends as she seems a bit confused. Past medical history includes gastroesophageal reflux disease and hypertension, for which she's taking omeprazole and Rampril. She smokes about 25 a day, drinks a litre of vodka every single day, and she's currently unemployed and lives with friends. So over the phone, there's a few more bits and pieces that you can ask for. So what else would you like to know? Most importantly, you always want to know what patient's observations are. We can ask for a bit more detail about the swelling. So where exactly is it? They've said the cheek, but whereabouts on the cheek and how big is it? Is there any possible airway compromise? It is an upper abscess, possibly, but it is always important to ask that question. Has she got any dental pain or is there any preceding dental treatment? And is it spreading towards the eye? And are there any abnormalities on examining the eye? We also want to know if they've done any investigations yet as well, such as any bloods or an OPG. Having a look at the information that we've got on the screen, have a think about, what are your main concerns so far? So we have a patient who is 45, so relatively young. She's been brought in as she seems confused. She drinks a lot of alcohol. She drinks a litre of vodka a day. Unfortunately, you'd be surprised it's actually not that much in comparison to some of the other patients you may see. But yes, it is definitely excessive. And she's also a smoker as well. So A&E tell you that they have taken her observations. So her saturations are normal at 96% on room air. Her respiratory rate is 20, so it's on the higher end of normal. And her heart rate is high, it's 105. Her blood pressure, 110/72, is relatively okay, but we do know that this patient is on an antihypertensive medication. So it's really important that we'll be able to compare to her baseline so we can look at other hospital records or a GP record. Temperature is 37.8, and that is also a little bit on the higher side as well. So we do have a talk on, sort of history and examinations for patients with facial swelling. So I don't want to go into too much detail in this for you, but these are the sorts of things that we should be asking. So we want a bit of a timeline of the events, and we can use the Socrates mnemonic for taking the pain and swelling history. Red flag questions should always be asked to every patient regardless of what you think is going on. So we want to be asking for any voice changes, which could be a sign of an airway compromise or a malignancy, any difficulties in swallowing, any numbness in the distribution of the second or third division of the trigeminal nerve, and any unintentional weight loss. We also want to ask about any non-specific signs of sepsis, which could be fevers or vomiting or lethargy. Because this is an upper swelling, we're also going to ask her about any changes to her visual acuity and pain to her eye. The significance of that will become obvious a little bit later. And then we just sort of want to ask a couple of things about eating and drinking. We want to know when she last ate and drank, just in case she needs to go to theatre, because she needs to be nil by mouth for 6 hours in order to be able to go to theatre. You always want to take a really good past medical history, drug history and allergies, and ask about the family history and the social history. And again, I don't want to go into too much detail as we have a whole talk on it, but this is kind of the general procedure for examining a patient with a facial swelling. So we always do an end of the bed assessment, check that there's no obvious airway compromise, and you also want to check their neck movements, which will tell you whether or not the infection could possibly be spreading into a deeper space within the neck. And yes, just as the rest, I'll just let you read that. So they have taken an OPG for us, and having a look, we can see that the patient's had an extraction of the lower right 7, And then if we have a look at the upper right 6, we can see that there's quite a bit of caries on there, and it looks like there's some PAP as well. Now on to the bloods, which is the focus of the talk. So I'm just going to take you through what what the important components are of a full blood count. So we want to have a look. So we're looking at the white cell count. So you can see the normal values is 4 to 11, and hers is 12.7. So that's high. So her white cells can be a bit lower than what we would expect in terms of if she does have a really bad infection, because patients with alcoholism don't mount an immune response as well as what healthy adults do because of the bone marrow suppression. So it's really important to look at the whole clinical picture alongside the observations. Looking at her hemoglobin, that is within a normal range. Her platelet count is 155. The bottom end of the normal range is 150, so that's bordering on low. Again, this is likely due to alcoholism because of the bone marrow suppression stops you from producing platelets. Her neutrophils are high, so that is likely to indicate a bacterial infection. If her lymphocytes were high, that would be more indicative of a viral infection. This MCV, so her mean cell volume, not something that you really need to be that aware of, but that is also high. And this happens in patients with alcoholism as well. Basically, the cells are a bit of a different shape, again, because of that bone marrow suppression. And then we want to look at her urea and electrolytes. I'm sorry, my recording is covering some of the normal values there, but so we can see that her sodium is normal. We'll go into more detail in this in the U&Es talk, but the raised urea and creatinine indicates that she has a kidney injury, possibly from dehydration if she's not really been eating and drinking because of her dental abscess, so she's going to need some fluid therapy. And that EGFR is her estimated glomerular filtration rate. That means her kidney function is falling, so that means that we need to be checking all the medications that we'll prescribe for her, whether or not it's safe to give at a normal dose. So the CRP, that is raised. The CRP stands for a C-reactive protein, and it's made by the liver in response to inflammation and infection. It helps activate parts of the inflammatory and the immune response, and it's really useful to monitor CRP as a marker of infections that are resolving or getting worse. It is important to remember that it lags behind the white cells. So what that means is that it basically takes a little bit longer to synthesize. So if a patient has an infection, you'll see the white cells go up first, and then maybe a day later, the CRP will come up a bit more. So it's possible that if we take that blood test again tomorrow, her CRP could, be well over 100. This is mentioned in quite a few other talks, but another investigation that we take in unwell patients is a blood gas. So this is, it's either taken from a vein or an artery, and it's basically pretty much an immediate result. Other bloods that we send off, we send to the lab, and it takes them a while to analyse it. This goes through a different type of analyzer, and you will get it looks like a shopping receipt with the results on. So the main difference between an arterial and a venous blood gas is that the arterial blood gas has accurate oxygen and carbon dioxide levels. So that is only taken for a patient that has low oxygen sat or a high resp rate. Because this patient has normal sats and everything, and we've taken the venous blood gas for her, because all of the rest of the parameters seen on this venous blood gas are seen on the arterial. So it provides, like I said, a really rapid result. So we can look at things like her lactate and her glucose and things. So having a look here, you can see that the main abnormalities are the raised lactate. So the normal range there is 0.5 to 1.5, and she's got a lactate of 1.7, and she also has a glucose of 14. Lactate is a marker of anaerobic respiration. So in septic patients, this indicates that oxygen isn't getting to tissues, which is why it can be high. This patient is also alcoholic. Acute alcohol intake can cause a raised lactate, but it's usually really high. If it's just due to alcohol, it'll be 7. There are other causes too, but it's just important to remember these two in the context of this patient as well. So with that high glucose as well, we want to have a think about why that could be high. So it is possible that the patient is an undiagnosed diabetic, or she has pancreas issues due to her really high alcohol intake as well. Any patient with an infection should have a random blood glucose sample just in case they are an undiagnosed diabetic. And if that's abnormal, like it is here, we take something called a HbA1c. So this is another blood test that gives an overview of the blood glucose control from the last 3 months. So it's one of the parameters that is used to diagnose diabetes. So going into a bit more depth into the indications and how to interpret a full blood count. So indications for ordering this are to look at inflammatory markers, to assess platelets preoperatively, and to assess like a hemoglobin pre-op and post-op as well. Pretty much all patients admitted to hospital will have a full blood count and a use-and-ease that's to assess their kidney function at a minimum. So having a think about the white cell count, so it can be high in patients with inflammation, so patients who are immediately post-op, if the patient has an infection, and it can be really, really high in patients with hematological malignancies such as leukemias and lymphomas. So if a patient has, if it's like really if you take a blood sample and the patient's white cell's like 40, but the patient is otherwise relatively well, or it's the opposite, it's actually really low. As you can see, that's also another sign of a hematological malignancy. You can ask the lab for a blood film. So this is where, like, usually they do it themselves, but they basically just put the blood on a microscope slide and have a look at the shape of the cells, and they'll tell you whether or not it's abnormal or normal and whether or not the patient needs further investigation by hematology. Other causes of low white cell count, patients who are undergoing chemotherapy and radiotherapy, they may be alcohol access, which causes immunosuppression, and some medications as well can cause a low white cell count. So we were sort of said earlier in our patient, because she's alcoholic, she doesn't mount as good an immune response. So having a think, can we think of any other patients that may also not mount an appropriate immune response? Again, this is important to consider because I would have a bit of a lower threshold for admitting these patients, even if we don't think, oh, they definitely need to go to theatre for drainage. So these patients are diabetic patients, patients who are on long-term steroids or other immunosuppressant drugs such as like the disease-modifying anti-rheumatic drugs like methotrexate, or any other sort of like immunomodulatory drug. Because infections in these patients can be quite disastrous, so I'd have a very low threshold for admission. So we look at the white cell count in conjunction with the neutrophils and lymphocytes. So I did mention earlier that if a neutrophil count is high, usually that would be in response to a bacterial infection particularly. They make up sort of about 40 to 70% of white cell counts, I think. Lymphocytes can be from a viral infection, but they can also be raised in some malignancies as well, like leukemia. And again, you'll see the reasons for either the neutrophils or the lymphocytes to be low are the same as any other white cell. So moving on to some other components of the full blood count. So hemoglobin, it's a protein found in red blood cells that carries oxygen. You probably remember that from dental school. So it's important to know that it can be really high in smokers or patients with COPD, and it's basically just because they've developed a higher count because they require more oxygen. It can also be seen as being quite high in patients with renal cancers or with polycythemia as well. A low level of hemoglobin can be seen in patients that have lost blood, which is quite common in our patients as they've had an operation. They may also have an anemia, and we assess that alongside the mean cell volume, which we'll go over in a second. It could also be low in patients with hematological malignancies again, chronic kidney disease, certain vitamin deficiencies, and if you are a female of menstrual age, you could be on your period as well. So the mean cell volume and the hematocrit give an indication as to a cause of an anemia if the HB is low. So if your mean cell volume is high, so that means you basically the cell is bigger than what it should be, you can get deficiencies in B12 and folate, and that's what causes the cells to be bigger. Like I said earlier, alcoholism also causes the large cell, and that's often just with a normal hemoglobin as well. If the cell volume is low, that is often due to an iron deficiency anemia, and if you want to check that, you can order a set of bloods, and it's either called hematinics or iron screening, depending on where you work. Patients who've had an acute bleed may also have a low hemoglobin as well, and a low mean cell volume because the body's creating new red blood cells to replace those that have been lost quite quickly, and as a result, the immature red blood cells are just smaller than the mature ones. So platelets, again, they can be raised in inflammation. So platelets are what your body uses to wall off abscesses and things. So if they continue rising with a sign of an infection, it is a sign that the patient could be developing an abscess somewhere. If they are low, in this context and for a lot of patients due to alcoholism, again from bone marrow suppression from alcohol, and it can also be due to certain medications, so antiplatelet medications as you would expect, but also very important for you guys to know, a lot of your patients for their VTE prophylaxis will be on a low molecular weight heparin, and that can cause a low platelet count. And so just looking at the C-reactive protein, so indications for ordering one, it's to assess the progression or the resolving of an infection or an inflammatory process. Like I said earlier, it does lag behind the white cell, so it might not rise immediately with an infection. And it is very expensive, so I wouldn't order it unless the patient has an infected or definitely has an infection or a suspected infection or inflammation. So don't order it like in a trauma patient because it just won't give you any further useful information. As I said, it is expensive. So going back to our patient, we've got a little bit of a synopsis of her there. So she's a 45-year-old female that we had with a right-sided upper dental abscess. Her observations were showing indicative of sepsis, and her bloods were also showing that she had an infection. So we want to institute the sepsis 6. We want to discuss this patient with our senior. We're going to admit her, and we're also going to keep her nil by mouth in case of theatre. Upper dental abscesses aren't often taken to theatre, and they're usually incised and drained just under local anaesthetic, but just in case, it's always safer to keep the patient nil by mouth and plan for theatre rather than if she's had breakfast or something and then actually your registrar thinks in the morning she does need to go to theatre. It's harder to kind of arrange that later on in the day. So the sepsis 6, we have a whole talk on this, so I don't want to go into too much detail, but you give 3 and you take 3. So we give oxygen, we give IV antibiotics, and we give fluids. The things that we take bloods and blood cultures. We take a lactate, and we take urine output and a urine dip as well. So, like we said, we're going to admit this patient. So there are a few other things that we need to consider and a few things that we need to prescribe as well. So if we look over to the side where the little synopsis is, we can see that she has GORD and hypertension. But she also smokes and she drank about 1 litre of vodka a day. So there's a couple of things there that obviously are concerns and that we would need to take extra consideration for this patient's admission. So what do we want to prescribe for this patient? So we need to put her on the alcohol withdrawal pathway. This is all going to be according to your local guidelines. So I would check those. I do have a slide on it briefly for the next slide, but it's really important that these patients are identified and put on this pathway appropriately because alcohol withdrawal can kill. So it's a really, really important aspect of management. It's definitely going to be something that's very relevant to your practice because unfortunately a lot of our patients do have a history of alcohol excess. She's a smoker, so we want to be able to offer her nicotine replacement therapy. Ideally, especially if she's for theatre, we don't want her smoking, and smoking is going to affect how her wound heals. Because that glucose was high on that blood gas, like I said, we would take a HbA1c blood test just to see if she is an undiagnosed diabetic. We also, once we've done whatever it is that we're doing, so either taking her to theatre or incising and draining under a local anaesthetic, we want to repeat those bloods to make sure that those inflammatory markers are resolving as well. And we also want to make sure that on the discharge letter, or if we're able to contact them, that the alcohol liaison service manage this patient in the community as well. So the alcohol withdrawal pathway, you will often hear it referred to as CIWA. That stands for Clinical Institute Withdrawal Assessment. So like I said, everyone's local protocols may be different. Usually we give IV Pabrinex, which is thiamine, the vitamin, plus a benzodiazepine, depending on if the patient is scoring on certain aspects of the assessment, if they're shaking or if they're agitated. So in my trust, we give something called chlordiazepoxide, but in other places they may give lorazepam. And as I said, it's always really important to liaise with the alcohol liaison team as well. And here's a second case. So you're back on night shifts and you've got a referral from A&E. So he's a 35-year-old male called Darren and he's got a fractured mandible. It's bilateral, so it's the left angle and the right parasymphysis, and he's been in a road traffic accident. That's what RTA stands for. They tell you that his past medical history is that he's fit and well, but he does have a penicillin allergy. He smokes about 15 a day, drinks about 20 units of alcohol a week, and occasionally takes cocaine as well. He lives alone and works as an accountant. So again, there's a reasonable amount of information here, but there is a few other things that you would like to know over the phone. So you must always ask A&E when they refer you a trauma patient whether or not they've been cleared of a head and a C-spine injury, and you must make sure of this, because once we've accepted the patient, basically any of these issues that they may have, they fall to us to sort out, which isn't really appropriate. So I would always ask, are they cleared of a head and a C-spine injury? If the answer is no, they need to be doing that. We know that he was in a road traffic accident, but we want to know a bit about the mechanism of the injury. You know, was he hit by a car? Was he in a car? And it's important to know this because you can think about other injuries that the patient may have. And on that kind of note, we also want to know, are there any other injuries? Because if the patient does have other injuries, say, you know, a broken wrist or something, we may need to coordinate with other specialties for theatre and ensure that the patient's got appropriate follow-up. You know, what investigations have they taken? Have they taken a CT scan or something? Because if they do just have a CT, we need an OPG and a PA mandible to assess the fractures pre and post-op. We also want to know if the patient's had any bloods done and what's the patient's observations. So just with this information that we have on the screen at the moment, there are some concerns and there are a couple of things you should be thinking about, because so the patient's been in a road traffic accident. Has he got, you know, multiple injuries? He also takes cocaine. You know, is that going to cause us a problem? So you've had to think about all those things and you've asked all those things on the phone. So the A&E doctor tells you that they are cleared of a head and a C-spine injury. Again, like I said, I cannot reinforce how important it is to make sure that they are cleared of that before they come to us. The patient was driving a car. So he was in a car accident. The airbags were deployed, but he still hit his face on the steering wheel. He's also complaining of a bit of shoulder pain. So the orthopedic surgeons are going to be reviewing the imaging. It's, you know, do take note of that because we might need to liaise with them. They have said that they took a CT head and facial bones, and that's what shows the fractured left angle and the right parasymphysis of the mandible. Like I said, we do need plain film x-rays, so we need an OPG and a PA mandible because that's going to allow us for a, you know, sort of a better assessment of the fractures for the ORIF. And they have very usefully sent his bloods off as well. So looking at the patient's observations, his saturations are normal, respiratory rate is normal, he is tachycardic, you know, his heart rate's 125. So what are the possible causes of this? You know, the patient is likely to be in pain. He's been in a traffic accident and has broken his mandible in 2 places. He's likely to be anxious from what's happened to him. He does also take cocaine, so that could also be a factor. And his blood pressure is also raised. Again, possibly due to pain and stress of the event, but like we said in the A2E assessment, we always need to rule out medical cause, so this patient should have an ECG. He should have an ECG anyway because he takes cocaine and that can actually cause arrhythmias, and his temperature is normal. So here is a picture of the CT reconstruction. So we can see where the fractures are, but we still need that OPG and PA mandible, and we need to make sure that this is done before the patient leaves A&E. Once they come up to a ward, it's nothing short of a nightmare trying to get them x-rays done, so we need to make sure that that is done in A&E because we would need them preoperatively. So we do have a session on trauma histories, where we'll go into more detail on how to take, you know, what you should be asking in patients that have had trauma. But again, I'll just briefly run through this. So we want a timeline of the events, what was the mechanism of injury, and is there any police involvement? We always ask for the red flags of a head injury. So have they lost consciousness, and if so, for how long? Can they remember everything? Did they have any seizures or anyone report they had a seizure? Have they been vomiting more than once since the incident? And, you know, is their consciousness level dropping? We also ask about the C-spine red flag. So is there any part of their neck that is painful? Are they having any difficulty moving their neck? Have they got any numbness or tingling in their fingers or anywhere in their arms? We also want to ask, what is the main complaint that they're having? You know, do they have a malocclusion? Is there numbness somewhere? If it's an upper mid-face injury, have they got any visual disturbances? Again, we need to know when they last ate and drank because it's important for them to go to theatre, and we always want to take a past medical history, social history. And here is kind of just a structure of how to examine a patient from trauma. Again, this has gone into a lot more detail in the trauma talk, and I'll kind of take you through how to actually palpate for everything and what you're looking for, but I'll just let you have a read of this as well. So we want to have a think about what further investigations we need. For the sake of simplicity, we're going to say that your examination findings are as you'd expect for a fractured mandible with no signs of any other facial injuries. So as we said, they've taken a CT scan, but we need that OPG in the PA mandible. Blood tests, so we want to think about, which bloods that we need for this patient. So if we look to the little synopsis there, he smokes, drinks more than is recommended, but it's not quite to excess, and he takes cocaine. So we want to take an FBC and use an EASE, which are always taken at a minimum for hospital patients because we want to look at his hemoglobin, his platelets. We also want to check his kidney function on those using EASE. We're going to give him medications, so we want to make sure that we don't need to adjust any of those doses. As I said earlier as well, we also do need an ECG because he uses cocaine, and because these patients can sometimes develop arrhythmias. He does also have quite a high heart rate, so we'd be looking to get one of those anyway. So his blood tests come back, and what do they show? So we can see that his white cells are slightly raised. Like I said, it's a sign of infection or inflammation. He has suffered an injury, so we would expect some inflammation going on there. Everything else is completely normal, and his kidney function, as we can see there, is also normal, so we wouldn't be looking to adjust the doses of any of his medications. So we're going to admit this patient because he needs to go to theatre to have his fractured mandible repaired. So what are we going to prescribe for him? So again, if we look at the synopsis, we can see that this patient is allergic to penicillin. So according to our trust guidelines, the alternative antibiotic to give him for prophylaxis is clindamycin. This patient's going to be nil by mouth, so we also need to give him fluids to make sure that he's hydrated for surgery, because often these patients are put on emergency lists and they can be fasting for quite a while and we don't know when they're going to go to theatre. So we want to make sure that they don't get dehydrated. We want to give him some pain relief, so we're going to prescribe some paracetamol and some codeine, and we're going to keep him nil by mouth. We also want to consent and list him for theatre. So this patient's now been in hospital for 2 days, and unfortunately he's still waiting for theatre. Unfortunately, this can be quite a common scenario depending on where you work and depending on what the emergency lists are like. So you're on call and the nurse bleeps you to review the patient because she tells you that he's feeling unwell. So again, there's not very much information. So over the phone, you want to be asking, what does she mean by that? How is he, and what are his current observations? So she tells you that he's feeling a bit dizzy and he's got some pain in his abdomen, and that the symptoms started a little bit after he came into hospital, but they've actually been getting worse. Again, not much of a history here. So for any patients with abdominal pain, again, we don't expect you to be taking, full histories with regards to, and sort of thinking about what could possibly be wrong, but very simple questions that you can ask is if they've opened their bowels and when they last opened their bowels, and if they've been passing urine, and if those two things are normal, is there any blood in there, is it loose, etc. So she's retaken his observations. So he's saturating fine, 98%. He's breathing a little bit faster at 21. His heart rate is still elevated, but it is lower than what it was before. If you look to the side, you can see what his obs were on admission, and his heart rate was 125. But his blood pressure has dropped quite a bit, hasn't it? It's now 101/84. However, depends on what is normal for the patient, and his temperature is normal. So these observations demonstrate something really important. It's always really important to look at the trend of the observations. So we know that he came in with a raised heart rate and blood pressure. But if you have a look, say, at his observations from the day before, you can see that both of those aspects had settled and had come within a normal range. So the raised heart rate, it could be volume loss. Like I said, the heart works harder to pump the same amount of blood around, and the blood pressure drop could indicate a reduction in volume as well, either through dehydration or bleeding. The patient did have some bloods taken that morning, but it turns out that nobody's actually seen them yet, so you're going to take a look at them now. So let's take a look at these bloods and what's wrong with them. So his white cells are 13.7. They were 12.5, so they've raised again. However, he's still got a fractured mandible and he's still awaiting surgery, so that inflammation is going to be ongoing. Most important thing here that we can see, because on his previous bloods, everything else was normal. He's now had a drop in his hemoglobin, because it was 136, and his mean cell volume is also low. So this means that there's a higher proportion of small cells. If you remember from the little explanation that I gave of how we kind of interpret hemoglobin and mean cell volume, I said that, if a patient is bleeding, your body basically creates lots of immature red blood cells quite quickly to replace the volume, and that's why the overall size of all those blood cells reduces, because they're immature. So he's got an anemia here, and we want to think about what are the causes of anemia. So does he have an iron deficiency? It's very unlikely this patient has developed an iron deficiency in the last 2 days. Is he bleeding? So he's got a low hemoglobin and low mean cell volume. And where is he bleeding from though? It's unlikely he's bled that much from his mouth, but he is complaining of abdominal pain. So we need to do an A to E assessment for this patient, and we also need to be informing our registrar that we've seen these abnormal bloods and this patient has, abdominal pain, because it is very important that a senior comes to review him as well quite quickly. So hopefully you've all seen the A to E assessment talk, so I'm not going to go into too much detail, but here is just kind of what we would look for and what we would do. So we always look from the end of the bed. So the patient looks uncomfortable, but he is alert and the airway is patent because he's speaking in full sentences to you. Your colleague has very helpfully bridled the mandibular fractures, a bit more on bridling in the trauma talk, but basically it's just where you put wires around the teeth to help hold the fractures still. It just helps with pain relief for the patient. In terms of the patient's breathing, there's normal breath sounds, his chest is expanding equally, he is breathing a little bit faster than normal, but he's saturating okay. Checking the patient's circulation, sorry, my recording has blocked some of that, but yes, his capillary refill time is 3 seconds, so it's relatively normal. Someone has listened to his heart sounds and says that they are normal, and his pulse is regular but is fast. His blood pressure, as we said earlier, had dropped a little bit, so 101/84, and he does have his cannula in, and the fluids are still running because he's now by mouth, he's waiting for theatre. So when checking the disability, the patient is alert, his pupils are equal and reactive, his blood glucose is 7.6, so that's fine, and his temperature is 36.3, which is also fine. So, like we said, we then go on to expose the patient and have a look for anything else that we may have missed. So you have a look at his abdomen, and he's got some bruising across the kind of the upper area, and it also hurts when you palpate the right upper bit of the abdomen. His calves are soft, they're non-tender, and there's nothing else abnormal elsewhere. So what do we want to do for this patient? So you've obviously already spoken to your own registrar, and they have told you to add on some bloods for this patient. So we want to check this patient's liver function. We also want to take a coagulation screen because they are bleeding. And amylase is a blood test that we take for most patients that have abdominal pain. It's basically, it can be an indicator of an abnormal pancreatic function. And we also want to take that venous blood gas because this patient isn't very well. So we want to have a look at the hemoglobin and the lactate and other things like that. We also are going to discuss this patient with general surgery because it sounds like, or it looks like he's having a potential intra-abdominal bleed, and they will tell you to take a CT thorax, abdomen and pelvis with contrast. So this case also demonstrates something really important. Mandibular fractures are very common to MATS-FACS. I imagine that they are probably the most common case that you will be clerking in and admitting from A&E. And the vast majority of our patients have these isolated injuries, and they're operated on, we fix their mandible and we discharge them and they're fine. But it is really important to remember that any trauma could have caused injuries elsewhere. And sometimes, A&E, they are there to do that primary and secondary survey, but nobody is perfect and things do get missed. This patient especially was actually, he was fine. He wasn't complaining of abdominal pain when he was initially seen. I guess it says that it progressed sort of from around the time of admission and was getting quite bad today. So it's really important that you always take a thorough history and that patients are reviewed daily. Any issues should be escalated really quickly in order to help prevent its deterioration, because this patient had actually suffered a blunt trauma injury to the liver when he had that car crash. General surgery are going to manage this one specifically conservatively. Not all patients need to be operated on, especially lots of abdominal surgery. It's very extensive, has lots of issues. So we are going to treat this patient's mandibular fracture. We're going to do the ORIF once the bleed has been managed and anaesthetics are happy and everyone is happy that the patient is stable. So here's some further reading for you guys on blood interpretation. So the SHOME, the Show Me app, has a really good guide on that. It's very handy because you can just have it on your phone. The Geeky Medics website has, how to interpret all the different blood panels, and we do have multiple talks on this here, so please do use that as well. And the eFace modules on the e-learning for health also have quite a few different cases that you can go through for this as well. So thanks very much for joining us. If you've got any questions, please don't hesitate to drop us an email at omfssurvivalguide@gmail.com. We'd also really, if you've got any feedback to give us on how this could be improved for next year, or anything particular that you enjoyed, please do fill out the feedback form below as well, or send it via email. You can also follow us on Instagram to see any details of our further courses and some flashcards as well that will hopefully help you get through the job. Good luck.